Hi, everyone. Once again, I'm Vincenzo Berghella. Welcome to an AJOG MFM update. I want to announce first and foremost that we actually have 20,000 plus Facebook followers. So thanks to the many of you who follow us every month. We're Mo Mhatre. Mo, delighted to be with you once again.
Thanks so much for having me. Welcome, everyone. I'm Mo Mhatre. I'm a maternal fetal medicine specialist at Tufts Medical Center and the director of the MFM Fellowship Program at Tufts. For those of you who are unfamiliar with our format, we go through all of the incredible articles from this latest issue, in July's issue, and we selected 4 articles that we wanted to highlight for you today. We try to pick articles that will be important for how we counsel and manage patients, both either inpatient or on the labor floor. And we like to select articles that have a robust study design and will be applicable not only to our MFM colleagues, but to all providers who care for obstetrics patients. We're going to be presenting visual abstracts, so a one slide quick highlight of the article, but please feel free to read the articles in detail on the AJOG MFM website. And to start off, as usual, we're going to start off with Dr. Berghella.
Thanks, Mo. And once again, thanks to all the authors who send these wonderful articles in. I think this is becoming a hot topic, cholesterol and in general lipoproteins in pregnancy. I saw another couple of articles in wonderful OBGYN journals in the last couple of months. This one, it's a correlation of cholesterol and lipoproteins with the diagnosis of preeclampsia, and a systematic review of 4 databases looking at, as you can see, many studies on comparing preeclampsia and controls. And they found that VLDL, very low density lipoprotein, was increased prior to preeclampsia, so it could be used as a predictive value. And also at the time of preeclampsia was increased, and the HDL, so the good cholesterol, as we call it, was decreased. I saw other data recently about cholesterol being correlated, if it's high, to LGA. So, as you know, these complications sometimes go together. I think that we always say, cholesterol increases in pregnancy, so why test it? It's always going to be high. But I can see a near future in which we begin to screen cholesterol, maybe even routinely, maybe to predict preeclampsia, maybe to predict LGA, and hopefully finding ways to, prevent those complications once we have this abnormal value. So very interested in future research.
Excellent. The next study we wanted to present today was a systematic review and meta-analysis of comparing high versus low dose oxytocin protocols for labor induction. Labor induction obviously is increased significantly throughout the United States and worldwide. And there has been, controversy about which kind of protocol is best. Do we start at low dose, 0.5 to 2 starting and increase it 1 to 2 millunits per minute? Or do we start at a high dose, meaning like at least starting at a starting dose of 4 and increasing it 3 to 6 millunits per minute? No one's quite sure about that. There has been a Cochrane review a few years ago now that could not find sufficient evidence to suggest one protocol versus the other. But that study was limited. They did note moderate to high risk of bias in the studies. And also there were a number of protocols that weren't really applicable to practice in the US of how they were dosing oxytocin. And since that Cochrane review, there's been some other additional studies that have come out. And so this group decided to redo a systematic review and meta-analysis and see if the data pans out now. And so they looked at 6 databases. There were 6 studies, 2 RCTs and 4 observational studies that crossed about almost 4,000 patients per low dose or high dose oxytocin. Their primary outcome was looking at the cesarean rate, and they found no difference in cesarean rate, nor in other concerning things like tachysystole or chorioamnionitis or other adverse neonatal outcomes. One issue, again, that came up was there was, more bias in the studies. And that made it challenging to really have sufficient evidence to say a high dose or low dose oxytocin protocol was better for labor induction, and certainly shows the need to have a well-designed large RCT to answer this kind of question. We know it's out there for augmentation, that it may help, but still the data is not out there sufficiently enough for induction.
Yeah, I agree. I think, 4 of the 6 were non-randomized studies, so, the evidence is limited for induction.
Yeah.
Completely agree. So next one, I'll do perennial outcomes of cystic hygroma, another systematic review and meta-analysis. And this was interested, a group of Reddit, Inka Oyelise, my good friend, collaborated with. They were trying to put together, as you could see, 57 studies, over 4,600 patients included with cystic hygroma. Basically, they found, not surprisingly, a very high incidence of genetic abnormalities, 55%. So when you see a cystic hygroma, surely this needs genetic testing, CVS, or amnio if it's 15 weeks or more. I think that with newer genetic testing, this obviously are older studies, I would assume that it's even before 55%. And certainly if you're doing exome, a lot of these have genetic abnormality. A lot of them also had structural anomalies, 42%, not as much if the karyotype was normal, but often, I would think of cystic hygroma most of the time have genetic abnormalities, and therefore many times having a structural anomaly. They did find, and it certainly reports that sometimes in the minority of the cases they can regress and resolve, 20% in your beautiful here infographics, Mo. But remember that most of the time these are serious, and they can be associated with trisomy 21, Turner, 13, 18, etc. And they didn't find any difference in outcomes if in subgroups with first trimester diagnosis or with septations, which some use for even diagnosis. So cystic hygromas are bad, and this is helpful. If you see a cystic hygroma today in your unit, this gives you some baseline that you can counsel the patient in terms of not only the testing you're going to do, but what the results of that testing is going to be.
Excellent. And to wrap up, our final article that we're going to present today is postpartum care in the neonatal intensive care unit. This is a Pelican study in RCT done in Philadelphia with a group in Philadelphia. And, we know that postpartum care is important. It's the 4th trimester, essential part of making sure that pregnant patients or recently delivered patients can continue to access appropriate care, given the high rate of maternal morbidity and mortality after delivery. But there's a known role of how doulas and midwives can be helpful in ensuring that care. But there hasn't been any studies of how those roles can play for patients in the NICU. And you can imagine, especially patients who have recently delivered, their babies are in the NICU, they're going to spend a lot of time focusing on their baby and maybe less time focusing on themselves and their own health. And so this was an RCT where they randomized postpartum patients who delivered babies who were in the NICU at less than 34 weeks. Their babies were expected to be there for at least a week. And they were randomized to either usual care or having a doula and a midwife postpartum care during their NICU stay for the entire time that their baby was in the NICU. And they measured the length of time it took before they received postpartum care, specifically blood pressure monitoring, depression screening, and contraception counseling. And what they found was that the patients who had the intervention received their postpartum care about 20 days earlier than controls, who usually were meeting them around the 6-week mark. And then only one patient who was in the intervention group missed a contraception counseling, but otherwise received the rest of their care, while 6 controls were missing core components, most often blood pressure. And I think one of those patients was even someone who had preeclampsia. So I think this speaks to the importance of involving patients and finding ways to get patients access for postpartum care, especially when they're in the NICU and maybe really having their focus on their baby. And this has a really, I think this was a really nice way to show the importance of doulas and midwives as well, and integrating them in the practice, because this is clearly showing that they're able to help rather than just waiting to see their doctor, 6 weeks after delivery. So I think it would be really nice to have a larger study and also have maybe an implementation science study on this, because this could have a real impact on our patients.
Yeah, I love this. The study is from the University of Pennsylvania, and I know it was a labor of love. These patients are so busy, with their little preemie in the NICU, decisions to be made every day, and it's hard for them to make a visit. So, let's, patients first. Let's meet them where they're at. They're going to be in the NICU every day, and this was, I thought, was a great idea, and I think hopefully will be replicated, like you say, Mo.
Yeah,
beautiful study.
I really liked also, if you think about it in terms of health disparities, there are the patients who are in the NICU, many of them are largely non-white, minority patients. And again, this is another way that we can try to lessen the health disparities by having our focus be on access to care, especially for those who are in the NICU.
Yeah, couldn't agree more. Well, thanks again. A wonderful session again today. The August 2025. It's in progress actually, and we'll see you in August. And thanks again, and happy summer, everyone.
Bye. Take care, everyone.